Gastroscope-assisted oral cavity and nasopharynx exam. Part 1. Oral cavity. The upper gastrointestinal tract extends from the lips to the small bowel. Assessment of the oral cavity is currently not part of a standard gastroscopy. We therefore developed a fast and feasible standardized cap-assisted gastroscope assessment of the oral cavity pre-endoscopy. This video demonstrates the assessment technique step by step and the normal anatomy of the oral cavity. We strongly recommend using a distal cap attachment. It supports in-focus views of mucosa, avoids readout, safeguards endoscope tip, comes at a very minimal additional cost, and the advantages apply for the entire upper GI endoscopy. We will now demonstrate correct cap position. Adjust the cap for centered views, with the cap only slightly protruding. Find your ideal scope position. Hold the tip of scope with a straight view touching the patient's incisors. Rotate the scope tip to achieve centered views. Remain in this fixed position for the entire assessment. Observe and document with 4 standard images. Image 1, tongue down. Image 2, tongue right. Image 3, tongue left. Image 4, tongue up. This completes the oral cavity assessment pre-endoscopy. Please see assessment now performed in normal video speed. Endoscope-assisted oral cavity assessment allows for good views. Assessment is easy to perform, requires less than 20 seconds, and can pick pathology for ENT review. Now we will demonstrate oral cavity anatomy. This is the soft palate, hard palate, buccal mucosa right and left, tongue, molar teeth. The cap allows in-focus assessment of oral cavity structures and abnormalities. Place scope tip onto the region of interest. The cap facilitates undisturbed in-focus views and document the findings for ENT referral. Papillae of the tongue. Filiform papillae help with sensation of touch. Fungiform papillae contain taste buds. Sublingual caruncle and the opening of the left submandibular duct. Frenulum. Here we see non-keratinized squamous epithelium of the buccal, labial, and alveolar region examined with narrowband imaging and near focus. Buccal non-keratinized squamous epithelium with typical intrapapillary loops, again examined with narrowband imaging and near focus. Hard palate consisting of keratinized stratified squamous epithelium. Soft palate consisting of non-keratinized stratified squamous epithelium. Here we see the transition zone between hard and soft palate with visible IPCLs using cap-assisted near-focus mode. Same view using narrowband imaging. Keratinized stratified squamous epithelium found on lips, dorsum of tongue, and hard palate. This is non-keratinized squamous epithelium of right buccal mucosa. The parotid duct opening located on the buccal mucosa opposite of second upper molar teeth. Part 2. Nasopharynx. An opportunistic nasopharyngeal assessment during routine gastroscopy is feasible. Our clinical experience using a cap-assisted approach in propofol sedated patients demonstrates a more than 90% success rate with enhanced visualization. The technique requires less than 20 seconds to perform. Screening may specifically prove valuable in high-risk patients or regions with high prevalence of nasopharynx carcinoma. Initiate the exam while withdrawing in the pharynx. The nasopharynx opening is seen behind the soft palate. Advance scope tip towards nasopharynx, then rotate and retroflex. Aim for 3 standard images. Image 1, centered view. Covena. nasal septum, posterior ends of turbinates, and the olfactory epithelium. The roof of the nasopharynx contains nasopharyngeal mucosa with dense lymphoid tissue. Image 2 contains the right eustachian tube opening, right torus tubarius, and the right fossa of Rosenmuller. Image 3 is of same structures on the left side. Here we see the transition to pharyngeal node keratinized stratified squamous epithelium. Salpingopharyngeal folds. And now we are back in the oral cavity with tongue and uvuline view. Let's see the same assessment now performed in normal video speed. In summary, unsedated pre-endoscopy oral cavity examination may detect otherwise overlooked pathology. A sedated post-gastroscopy nasopharynx exams provides opportunistic screening in high-risk patients and regions and can be performed cap-assisted using propofol with more than 90% success. In conclusion, oral cavity and nasopharynx examination are safe and rapid additions to routine gastroscopy with enhanced diagnostic yield, and the distal cap attachment is essential for best outcomes.